I'm Rodrigo Diaz. And together with my colleague Francisca Morera, we have prepared this video tutorial demonstrating the technique for placement of a large-bore thoracostomy tube. This technique should be considered when repeated thoracentesis has previously been required due to the accumulation of air or fluid within the pleural space. It is also indicated when pleural lavage is required, such as in cases of pyothorax. This procedure is not free of potential complications. Therefore, precise technical execution is required to minimize risks and ensure adequate therapeutic efficiency of the thoracostomy tube. This video demonstrates the correct site of insertion, dissection and debridement technique of the tissue, controlled and oriented movements into the pleural space using hemostatic forceps and a trocar. Finally, tube insertion details, fixation to the skin with sutures and application of a thoracic bandage are demonstrated. Materials required for thoracostomy tube placement and fixation include curved hemostatic forceps, thumb forceps, needle holders, scissors, a scalpel, large-bore thoracostomy tubes, and non-absorbable suture material. The hemithorax should be clipped and aseptically prepared around the tube insertion site. This site is typically located between the 7th and 10th intercostal spaces, in the mid-dorsal region of the thorax. The ribs and intercostal spaces should be palpated to identify the incision site and the point of entry into the pleural space. When possible, the area may be marked using a sterile skin marker. A skin incision is made slightly larger than the diameter of the tube. Then, using curved hemostatic forceps, controlled dissection of the tissue is performed, forward and cranially oriented for 1 or 2 intercostal spaces. Creating this subcutaneous tunnel helps to improve the seal and decrease air leakage from the tube. Once the selected intercostal space has been reached, the hemostatic curved are directed toward the thoracic cavity to perform blunt dissection through the intercostal musculature. The curved hemostatic forceps are then reoriented to a perpendicular angle relative to the thoracic wall. Controlled force is applied to penetrate the remaining intercostal musculature and the parietal pleura. During this maneuver, insertion depth should be limited by placing a finger or the non-dominant hand near the distal segment of the forceps. This measure, combined with temporary interruption of positive pressure ventilation, helps to reduce the risk of iatrogenic lung injury. Once the pleura has been penetrated, the tips of the hemostatic forceps is opened, creating a space that allows insertion of the thoracostomy tube. The tube is advanced in a cranioventral direction. Once the tube tip is adequately positioned within the thoracic cavity, the hemostatic forceps are removed. Ideally, the tube tip should be positioned approximately at the level of the second rib. It is very important to verify that all tube fenestrations remain within the thoracic cavity. The tube may be temporarily occluded using tube forceps or connected directly to the drainage system. For placement of a thoracostomy tube using a trocar, the initial skin and subcutaneous approach are the same as previously described. The tube is positioned perpendicular to the thoracic wall. Follow the same maneuvers described previously with the hemostatic forceps. Insertion depth should be limited by placing a finger or non-dominant hand near the distal segment catheter and tube, while controlled force is applied to penetrate the intercostal musculature and pleura. Once inside the thoracic cavity, the insertion angle is decreased. The tube is directed in a cranioventral direction while the trocar is withdrawn. To secure the tube, a purse string suture is placed around the skin incision. Care must be taken to avoid puncturing the tube during needle passage, as this may result in air leakage. The tube is then secured using a finger trap or Roman sandal suture pattern. After completing at least 5 wraps, the knot is secured to the skin with a simple interrupted suture to prevent tube traction. Handling of the thoracostomy tube and evaluation of the insertion site require strict aseptic technique. The tube and its connections should be adequately covered to prevent accidental removal by the patient, using non-compressive bandages. These bandages should be changed at least every 24 hours. At each bandage change, the integrity of the sutures, the presence of subcutaneous emphysema, pathological secretions, or seroma formation should be evaluated.